ultrasound intervention, tips and tricks. So what do we mean by ultrasound guided intervention? Well, there are three main areas to consider. One is aspiration, the other is injection, and finally biopsy. And really, a lot of the interventions that I perform in the musculoskeletal system are injection therapies, and because I work in a cancer center, I also perform a lot of biopsies. So what equipment do we need? Well, it depends really what procedure you're performing. You don't always need a probe cover, you don't always need a drape. And for most of my interventions, for example, injections of the shoulder, I'll use steroid and local anesthetic. And in terms of biopsies, often it's a soft tissue biopsy, so I'll use a biopsy needle that has a cutting action, such as a Temno needle. There are some general tips that I'd like to give you with regards to how you perform ultrasound-guided intervention. The first is that we should enter along the plane of the probe, so we should enter longitudinally so that we can have full visualization of the needle tip. The other is that we should have the needle as parallel as possible to the probe. So if you want to have good visualization, we need to have the needle as parallel as possible to the probe. And finally, when you're holding the probe and the needle, just move one of those. You know, hold your probe steady and move your needle if you can't see it, or vice versa. Hold your needle steady and move your probe. So it's one or the other, rather than move both at the same time. If you are performing soft tissue biopsies, it's often useful to have Doppler to assess the vascularity of the area that you're going to biopsy. You want to identify the different tissue compartments and be aware of the incision site that a surgeon would make. Because what we don't want to do is to interfere with the surgical approach and have seeding of tumor, for example, down a biopsy tract that is not excised by the surgeon. And of course you want to avoid necrotic regions, highly vascular lesions, and atypical areas within a tumor. For example, this is a thigh. You can see there's a muscle tumor, which is what we call a myxoma in the posterior compartment of the thigh. And you need to know your compartmental anatomy to realize where the different compartments are. So in the orange is the quadriceps compartment, in the blue is the adductor compartment, and then in the green you have the hamstring compartment. And if you are approaching this for a biopsy, you want to make sure you avoid the sciatic nerve, which is there in the red, and also the femoral neurovascular bundle. And you wouldn't want to take an approach like this, crossing 3 compartments, or like this, crossing 2 compartments, because you can then spread tumor from one compartment to another. And of course, the obvious approach is just to do a direct approach with causing the minimal amount of tissue to reach the tumor. And also just be aware of where the surgeon will make the incision. So we're going to look at the hip to start off, and we're going to talk about hip intervention, hip joint injections. We're going to talk about iliopsoas injections, injections around the greater trochanter, and then finally groin injections. And then moving around to the back, we'll mention briefly as well hamstring tendon injections. So let's look at hip injection and aspiration. This is one of the commonest procedures that I'll perform. And you want the patient lying supine. You're going to look at the joint in the longitudinal plane. And your target usually for entering the joint is the femoral neck. And if I'm injecting, usually I'll inject a mixture of steroid and up to 9 ml of local anesthetic. This is an example of how I would aspirate the hip. If you think of what we're looking at the femoral neck. There's the iliopsoas muscle lying anteriorly, and there's the effusion. And what we would do is put a needle down, usually at a slight angle so that we can have visualization. But it's possible once you've seen where the effusion is, that we will enter directly down. And this is an example here using a curvilinear probe. And you can see the needle coming in at an angle over there. The reason we don't see the needle extremely clearly is that it's not horizontal to the probe. But of course, because we're approaching a deep structure, there's no way I could have that needle completely horizontal. So there are certain things you can do to help you. One is to move the needle slightly so that it produces more echoes. The other is when I start injecting, I expect to see the injectate swirling around within the hip joint, and you can see the small particles there of the steroid swirling around within the hip joint. And then in certain circumstances, what we will feel, particularly about aspirating hip replacement, is that you'll feel metal touching metal, and you'll have that firm sensation at the end of your needle. And you can see here, there's the needle coming in, going to the femoral neck, which is kind of highly echogenic because that's metal over here. Iliopsoas injections can be useful for patients who have a clicking iliopsoas tendon, or if they have iliopsoas bursitis. If there is no fluid, we can aim for the deep aspect of the iliopsoas tendon using a transverse approach. If there's fluid, we can just take the most direct route. So the approach is similar to a hip joint injection, but what we do is we aim to inject just beneath the iliopsoas tendon. Remember, the psoas comes over the top of the hip, so we don't want to reach the hip joint, we want to just inject just below it. And you can see in this patient, there's an iliopsoas bursa that is distended, and we aim to put the needle down to it. This patient had a very distended iliopsoas bursa, and we wanted to know whether there was infection or not. Oh, that went through very quickly for some reason. Just keep that through again. And you can see here, we're approaching the iliopsoas bursa from the side, just using a direct approach and moving the needle so that we can visualize it. You may have a patient who complains of a click when they move that hip in certain positions, what we call the snapping iliopsoas tendon. And you can see here, this is the muscle belly of the iliopsoas. And as the patient flexes the hip and abducts the hip, what happens is the muscle belly of the iliopsoas twists. And then as the patient straightens the leg again, that muscle belly untwists, but in a snapping action. And some patients will find this very uncomfortable, and you can actually hear a snap as that occurs. And the region that I look for this is just above the hip joint. So we're looking at the iliac rim over here, just above the hip. And this is the muscle belly. This is the tendon here. And you can see how that tendon flops down and forms a snap as the patient performs this maneuver. And one of the things we can do is inject this area just deep to the tendon. So there's the muscle belly, there's the tendon, and we can inject in this area to settle down the symptoms and relieve the patient's pain. Pain around the greater trochanter, or what we call trochanteric pain syndrome, is extremely common. It usually occurs in middle-aged women who complain of pain at the side of the hip rather than in the groin. And they will say that there is pain when they're lying on that side. So at night time when they're in bed, they can't lie on that side. And also when they're walking, they'll have pain at the side of the hip. And what this represents usually is a problem with the gluteus medius tendon. And sometimes there's bursitis, what we call trochanteric bursitis, but sometimes it is tendinosis. Some people refer to the gluteus medius tendon as the rotator cuff of the hip, because it's like the rotator cuff in the shoulder. And in the same way that we get impingement in the shoulder, we can get impingement in the hip. And so what we're often asked to do is inject some steroid around the tendon here. And so we have the patient lying on their side. We put the probe, I like to put it along the fibers of the gluteus medius muscle belly as it inserts down onto the tendon. And then aim my needle to the deep surface of the gluteus medius tendon, and then inject into the region deep to the tendon, and then also come back a little bit and inject some superficially around the surface of the gluteus medius tendon. Adductor injections, this can be useful in patients who are usually sportsmen who will be asked to do this for. These patients will have chronic injury or enthesopathy of the adductor tendon, and what we do is we get the patient to abduct their leg, have a look at the probe in that position, and aim the needle down accordingly. It's not the nicest injection to have, as the guys in the audience might imagine, but it works well if the pain is originating from the adductor tendons. So this is an example here of a cleft, partial tear of the adductor longus tendon, and what we do is we can inject deep to it to help relieve some of the symptoms. Hamstring injections, again, we often are asked to do this for sports people. The structure to be aware of is the sciatic nerve. You can see here on this T1 weighted MRI scan, in the orange is the quadratus femoris muscle. The yellow arrow points out the sciatic nerve. I'm going to flip the image here so that we can then look at the equivalent appearance on ultrasound. There's the sciatic nerve on the flipped image, and there it is on ultrasound. And we have the ischial tuberosity on the left of the image there, and the proximal femur on the right of the image. And the hamstring insertion, of course, is close to the ischial tuberosity. And you can see its proximity to the sciatic nerve. So when I inject the hamstring tendon, I do warn patients that they may have numbness in the sciatic nerve, and they may end up with some weakness for a few hours after the injection. Again, I have the patient lying on their side. Normally it helps if you bring the knee up or flex the knee. I look longitudinally and inject along in this direction. And so this is where what the hamstring insertion looks like, inserting to the ischial tuberosity, and that's where I place my injection. And afterwards, you can see the injectate kind of distending this area. I'm moving on now to the foot, and in the foot, we'll talk about Morton's neuromas, plantar fasciitis, and the Achilles. These are three really common causes of pain in the general population. A Morton's neuroma is essentially a thickening of the nerve as it passes between the metatarsal heads. And women will be more commonly affected than men because they wear shoes that lead to compression of the intermetatarsal nerve. So we scan from the sole of the foot at the level of the MTPJs, and we sweep across the foot, compressing the dorsal aspect of the foot. And what we see in a patient who has a Morton's neuroma is this soft tissue that looks as if it's like a mushroom emerging from between the bones. And in the sagittal plane, the Morton's neuroma looks like a round hypoechoic mass, which is often compressible. So when it comes to treatment options in a Morton's neuroma, you can put insoles into your shoes, orthotics, which help about a third of patients. So it changes your gait by using these insoles. But often that is ineffective, and so patients will end up having injections, sometimes of steroid, sometimes some practitioners use alcohol to try and scar the Morton's neuroma. And then if none of that works, then a surgeon can go in and try and cut the actual Morton's neuroma out. Alcohol produces neurolysis, by which I mean the nerve is injured basically through dehydration and necrosis. And this technique can be painful, so you have to use it with lots of local anesthetic. And the trouble with this technique is that it requires several injections for it to become effective. But the people who use it claim a high success rate. But in practice, I think it's quite a damaging procedure to perform and can cause a lot of scarring. So it's not widely used in the UK. Steroid injection, on the other hand, is much more widely used. Often a single injection will be effective. What this does is it decreases the inflammation in the intermetatarsal space. And we can give up to 3 injections in a year. And generally speaking, I would say, the results are good, with over 70% of patients improving. If you inject too much steroid, of course, you can have certain side effects from steroid, such as atrophy of the fat and some weakening of the ligamentous structures. So too many injections are not a good thing. In terms of how I approach for a Morton's neuroma injection, I think the dorsal approach is the least painful. This is the appearance I have when I look at the ultrasound of the Morton's neuroma, and this is the approach I would take. Remember, I'm coming from the dorsal aspect, and so my injection needle is often not clearly seen because I'm coming in at such an angle that the ultrasound machine doesn't see it well. But I know exactly where my needle is because it is just going to be beneath the skin from where I'm scanning. So this is an example of me knowing my spatial position of my needle without actually being able to visualize it because of having the experience of knowing where my needle is in relation to my probe when I'm performing the procedure. And when we inject, often we'll see a filling of the intermetatarsal bursa, such as this, and so the fluid swirls around within this potential space. After the injection, the patient should rest for 2 or 3 days. Usually when we give these kind of pain-killing injections, we give a form to the patient to fill out, what we call a pain diary, so that they can feed back to us how the injection has worked. And then when we receive this back, then I put another report on the system, on the PAC system, so that there's a record of the outcome from the injection. And this is an important thing to do so that Okay, so this is an important thing to do so that we have a record of what's happened with the injections. And obviously, if the injections have been ineffective, then we know not to repeat them. The plantar fascia is a very common place to have problems, and often it can be part of a metabolic syndrome. So patients who are diabetic or who are obese will have plantar fasciitis. And then the other group of patients will be those who do a lot of sporting activity, like runners. And what we tend to see is a fusiform swelling of the plantar fascia, which should be a nice thin structure normally. And you can see here how it's thickened, hypoechoic. You can see a small bony spur at the calcaneal insertion. And that should be the thickness of the plantar fascia, and you can see how swollen this looks. And what I tend to do is approach from the sole of the foot. I inject some superficially of local anesthetic, and then go through and inject into the deep portion of the plantar fascia. And then I follow that with needling of the plantar fascia. And you can see here, I'm going through and I'm injecting some more deep. So that there's lots of local anesthetic around the plantar fascia. You can see that there's pooling of some local anesthetic superficially, and now there is some deep to the plantar fascia. And then when I've done that, I can jab the needle in and out of the plantar fascia. So this procedure of dry needling or tenotomy, where we actually damage the tendon or damage a ligament, as in this case, is thought to stimulate healing within the structure. And it may seem counterintuitive because it's already a structure which is damaged, and here you are causing more damage. But what we know is that by doing the needling, the damage results in the release of various growth factors, and it causes microhemorrhage into that area. And there's good evidence that that somehow incites a reparative process, a repair process, which can then enable the patient to improve. And we have many patients where everything else has failed, and yet by doing this kind of procedure, the patients will get relief in the long term. You can also use a medial approach, where you come and inject superficially, and then redirect the needle deep to the plantar fascia, and do a similar procedure as using the longitudinal approach. But I prefer to use the longitudinal approach because I can see the plantar fascia more clearly. The Achilles tendon is a tendon which is one of the biggest and strongest tendons in the body. And for many years, we've been looking for a solution for Achilles tendinosis. And there are many different ways of trying to deal with Achilles problems. One is to actually inject the patient's own blood into the area of abnormality. Another is to perform dry needling, as I've described, in the plantar fascia. And then more recently, in the last few years, some very clever doctors have started using a procedure called high volume guided injection, whereby we essentially do a stripping of the tendon by injecting a lot of local anesthetic around the tendon. And it's thought that works in several ways. One is that it gets rid of adhesions around the tendon. And actually surgically, if a surgeon was to go in to try to fix the tendon, that's what they do. They go in and strip the tendon. The other is that it's thought to interfere with the blood flow to the tendon. And we know that abnormal tendons also have an abnormal blood flow to them. And and so it somehow seems to interrupt the blood flow to that tendon. Let's look at autologous blood injection first though. We know that localized bleeding occurs after injury, and platelet-derived growth factor, which is found in blood, initiates an inflammatory cascade for the repair process. And so we think that if we inject autologous blood and combine that with dry needling, what happens is that we're putting in an additional amount of these humeral and cellular factors that will initiate the healing response. And so rather than just inject the blood or just perform the dry needling, we do both at the same time. And so what we do is we put in some local anesthetic, then we do the dry needling of the tendon. And we can either use just plain blood that has been drawn off the patient, or we can take off a larger volume of blood and spin that down in a separator to get PRP, or platelet-rich plasma. And in certain tendons, such as in the common extensor origin or tennis elbow, there is some evidence that it works better than just standard injections of steroid, but also seems to work better than physiotherapy, which is actually considered the gold standard. But in several reviews, this is the National Institute for Clinical Excellence in the UK. This looks at the evidence that is okay, we're back. The National Institute for Clinical Excellence, NICE, has done several reviews looking at all these different techniques, and it says there's still not enough evidence to support its routine use. The final procedure that I want to discuss is this high-volume image-guided injection, HVI-GI it's called, and we inject up to 60 ml of fluid around the Achilles tendon, and the theory is that we disrupt the neovessels, and as well as that, strip the adhesions off the Achilles tendon. And you can see here some local anesthetic being injected into the pre-Achilles region. Another example here in cross-section where there's a needle in the paratenon of the Achilles with distension of this region. And then we can also combine the high volume guided injection with needling of the tendon, so that you have a full house of different techniques that you're using to try and treat these tendons. The trouble with the dry needling procedure is that no one has done any good studies. There's no randomized controlled trials. We don't know what caliber of needle to use. We don't know how many passes should be made through a particular area. We don't know how fast we should do it, whether we should just go in once or twice very slowly or do it very quickly. And so practitioners around the world are doing it in different ways, and as an individual, I feel that I know what I'm doing, but actually it is quite, what I do might be quite different from what someone else is doing. And so the experience of the practitioner, I think, counts, but it's still an area where we need to have more evidence. This is what a high volume guided injection looks like after it's been given. You notice that there isn't pooling of the local anesthetic or saline in the pre-Achilles region. It seems to dissipate into the tissues, and so you can quite easily put in 50 or 60 ml without any problem. in this region, even though it seems like a lot. A question that is often asked is whether after performing interventions you need to protect a particular tendon. Usually you don't, but the Achilles might be the one exception, because the Achilles is prone to rupturing if you interfere with it. So one thing you don't want to do is cause an Achilles rupture, because it's as bad as having a fracture in terms of the recovery. It takes at least 3 to 6 months for an Achilles tendon to repair. So some people might put the patient into an air cast boot so that they are immobilized for 2 weeks after the procedure. There are also problems that can develop because you put a patient into a boot. It may be that because you immobilize the patient, they develop a deep vein thrombosis. So it's important to think carefully about whether we use a boot or not, depending on the patient that we see. I must say, in my practice, we have tended to put the patient into a boot to protect them for 2 weeks after performing interventions. In terms of the evidence for high-volume guided injections, there is some evidence that you get at least good short-term results and good medium-term results. And these are results in patients where other procedures have failed. And finally, we're going to talk about intervention in the shoulder and subacromial injection. This might be one of the most common injections that I perform in my practice. And we use it in patients who have impingement or bursitis, or even rotating cuff tears that are painful. And so this is a patient with bursitis, you can see here, with the bunching of the bursa. And what we aim to do is to inject into the bursa. It doesn't matter which approach you take, as long as you reach the correct position on top of the bursa. And this is an example of an injection here, where you can see that the fluid dissipates into the subacromial space and flows away from your injection tip. When performing these injections, if you see pooling of the fluid, it tells you that you're actually not in the right space. What you want to see is that the fluid flows away and doesn't pool in one area, because then that tells you that you are distributing the fluid into the subacromial space. And you can see here that the fluid filling up. Another example here, the needle tip going in, injecting, and you can see the fluid on the right side of the screen bubbling along, telling us that we're actually in a potential space rather than just injecting into a pocket of fluid. Another example here, where there's fluid just kind of filling, and I can see that as I stop injecting, the space kind of collapses down because it's flowing away from that area. Calcific tendinitis is a very painful condition, and when you see patients presenting with this, sometimes they can barely move their shoulder, and the clinicians will often suspect that there's an infection. We know what the plain film findings are like. I showed you the slide on my earlier talk. We know that women are more affected than men. Usually it's in the 4th or 5th decade, and they get severe pain and maybe even a fever. And you can see here the calcification in this patient. There's the axial view showing the calcification anteriorly, and this is the same patient showing a big lump of calcium with posterior acoustic shadowing. And that same patient there in the painful phase with lots of ill-defined calcification within the rotator cuff, and also some pockets of liquefied calcification. So this is a nice case to try and aspirate calcium. Another example here where there is extrusion of the calcification into the bursa, And so if you look carefully, you can see that there is a calcification extending over the surface of the tendon. And if you notice this calcification here, because it's still in its relatively early phase and it hasn't become solid like a stone, there isn't that much posterior acoustic shadowing. So there are several treatment options. One is to perform a procedure called barbotage. The other is shockwave therapy. And then finally, and our last choice is surgery. So for the French speakers amongst you, you know that barbotage is to kind of dabble. It's what a duck's beak does when it's in water. So it's this kind of action of moving in and out of the water. And that's what we do when we put the needle in. We dabble the needle, which is why we have the term barbotage. And we can use it to aspirate and inject the tendon. So if you imagine you've got an area of calcification, one of the things that you can do is to go into the calcification, just into the bursa, inject some local anesthetic, because remember the patient is usually in a lot of pain. And then you can do this procedure of breaking up the calcification that's there. Recently, what I've started doing is trying to aspirate the calcium. So it's not necessary to be able to draw the calcium out. The important thing is to break it up. But of course, if you can draw some off, it is useful. So this is an example here where I'm breaking up the calcium. This is an example here where I'm actually into a liquefied portion of calcification, and I'm actually trying to aspirate. And then more recently, one of the things I started doing is injecting local anesthetic actually into the tendon where the calcification is, and allowing that local anesthetic to dissolve, for some of the calcification, to dissolve into that local anesthetic, and then you can draw that up. Sometimes the needle gets blocked if the calcification is too dense, but usually you can end up drawing back some calcification. It's possible to use two needles, where you put a needle in and inject, and then try and aspirate the calcification from that region. And you can then end up drawing off quite a substantial amount of calcification when these patients present. And so if you look at a slide showing, this is a patient with some calcification that I've drawn back. And you can see how thick that calcification is, and it's, at least in this stage, it's kind of suspended in some of the fluid that's there, but you will get all this precipitate at the bottom of the bottle. And there's good evidence from multiple papers that what we can do is significantly relieve the patient's pain, and as well as that, help them prevent having any surgery. One of the last things in the shoulder as well is injection of the glenohumeral joint. So most of the procedures we perform in the shoulder are directed to the rotator cuff. Sometimes we'll want to either inject the shoulder for purposes of doing an arthrogram prior to an MRI scan, or distend the shoulder in cases where the patient has adhesive capsulitis, or what we call frozen shoulder. In terms of approaching the patient, we come from behind. We look at the posterior aspect of the glenohumeral joint. This is an MRI scan, just to help you orientate. You can see the joint is distended with contrast. If we now overlay the ultrasound examination, we can see where we want to go. There's the infraspinatus tendon coming posteriorly. There's the glenoid. There's the labrum of the shoulder, the humeral head. And we aim into the joint in this direction, passing the needle onto the humeral head, and then aspirating. And of course, you don't want to be too close to the margin of the glenoid because you might damage the labrum. So the target is just slightly away from the humeral head. And those of you who do perform arthrograms of the shoulder will know that you can use a posterior approach to the humeral head to inject it. And this is what we might expect to see. You can see the echogenic kind of needle coming in here. Again, not fantastic visualization of the needle because we're not parallel to the probe. But you can see that there's good, as the needle enters, there's good distension of the joint. Let's have the needle as horizontal as possible. And that's the joint distending now. And sometimes, if you want, you can put Doppler on to see the swirling effect of the fluid as it sends through. And this is, we expect the joint to become nicely distended. A couple of years ago, one of my fellows and I wrote up in skeletal radiology an alternative approach for injecting the glenohumeral joint. And this is what we call a targeted rotator interval injection. And what we do is we see the anterior interval. This is the long head of biceps. This is the coracohumeral ligament coursing over the top of it. This is the supraspinatus tendon. So long head of biceps. And this is the subscapularis. And underneath over here is the superior glenohumeral ligament. And as I said, that's the coracohumeral ligament there. And so this is the anatomy you need to be able to recognize. And what we do is we inject to the superior surface of the biceps. And we will find that the joint becomes distended as we inject. So even though it seems that we're not entering the actual glenohumeral joint itself, we know that the biceps tendon sheath communicates with the glenohumeral joint, which is why it's a useful approach to use. The other benefit of this injection is that we target the area that we know becomes very inflamed in adhesive capsulitis. If you do an MRI scan, it's this area where you see the changes on the MRI scan, so we're targeting this area. So what we've done in this session is we've covered hip intervention, we've looked at injections around the foot for Morton's neuroma, plantar fasciitis, and Achilles tendinopathy. In the shoulder, we've spoken about subacromial injections and barbotage, as well as glenohumeral injections. And this is my kind of final slide. This was in the Christmas edition of the British Medical Journal. And this is what they call the parachute approach. And this is the use of parachutes to prevent death and major trauma due to gravity. And the comparison here was that there is a lack of randomized controlled trials for testing parachutes. But there are still situations where such trials are considered unnecessary. So that's what we're doing in many musculoskeletal procedures. We're not performing randomized controlled trials because it's a very difficult thing to do for certain procedures that we're doing. And yet we're using a clinically directed approach and using clinical experience for many of the therapies that we're undertaking. Thank you for your attention.
Như vậy thì ông đã báo cáo xong thì các anh chị có câu hỏi gì không? Have you some question?
advice? Is anyone performing musculoskeletal interventions? Only one, the professor.
Thưa chủ tịch, thưa phó giáo sư, em có câu hỏi là cái viêm, trường hợp viêm gân ấy, thì theo thầy là tiêm nó vào chỗ nào của cái gân viêm là tốt nhất, ví dụ tiêm dưới bao hay là ngoài bao hay là trong cái gân. Nó lại câu thứ hai là thầy có dạy về những cái kén bao hoạt dịch ấy, nhưng mà không biết thầy có đã can thiệp để kén bao hoạt dịch trên siêu âm bây giờ chưa? Nếu mà có thì làm như thế nào?
Has two questions. The first question is about the brain tendinitis. Which passion in the middle and the anterior, the middle, the anterior, and the posterior, the ten. We need to adjust.
So it's the Achilles tendon or general tendon. So I suppose it depends which procedure we're doing. If we're doing the needling procedure, it's the middle of the tendon which I am approaching. Often one of the things that I do is like to perform the procedure where there is the most vascularity within that tendon, because usually a tendon has no vessels, and usually the worst affected area is where the blood vessels are. So I use Doppler to help me define the area that I want to target. There are some tendons where even if there's severe tendinosis, we don't see increased vascularity, like the rotator cuff. For some reason, we don't see increased vascularity there. But in tendons such as the patellar tendon, the Achilles tendon, when there's abnormality in those areas, usually there's a lot of increased blood flow, and that's what I will use to target the abnormality.
The second question is concerning the Biopsies. Give me the best one for the treatment of Biopsies, intervention or surgery.
So Biopsies are extremely common, and they will often increase in size by themselves and decrease in size by themselves without any intervention. So if it's very troublesome, then sometimes the surgeon will ask us to inject some steroid or try and draw fluid up. But in most cases, actually we don't like to interfere with it, because it's almost a normal finding. If you report the MRIs, you see a Baker's cyst very, very often. And what we don't want to do is stop treating these things unnecessarily. Because once you establish that you inject Baker's cyst or aspirate the Baker's cyst, you'll then have a lot of referrals, which will be for no good reason. So usually I would say leave the Baker's cyst alone.
Chị có ai hỏi nữa không? Nếu mà không có ai hỏi thì tôi xin mời tiến sĩ Nguyễn Quốc Bảo Quân, chủ tịch hội, có vài lời cảm ơn giáo sư.
There is no question.